Hello everyone. Welcome to this webinar on ketamine-assisted therapy. My name is Caterina, and this webinar is part of a series of webinars organized by Illuminismo Psichedelico in collaboration with Associazione Luca Coscioni. This event was actually made possible thanks to the collaboration of several organizations active in the field of psychedelic science and therapy in Italy, including Simepsi, which is the Italian Society of Psychedelic Medicine, and Maps Italia, the Multidisciplinary Association for Psychedelic Studies Italy. And it's quite rare to have all these groups represented in one event. Each of them contributes in its own way to advancing research, education, and dialogue around psychedelic assisted therapies. And it's really an honor to have all of them together today. So thank you. And today we will focus on the use of ketamine-assisted therapy in Italy. Of course, we know that ketamine-assisted therapy is increasingly integrated into clinical practice worldwide, but in Italy it remains almost non-existent. So we will discuss what the barriers we have in Italy, what are the major challenges, and we will try to make this therapy more accessible for Italian patients in the future. And we will try to do it by listening to experts all around the world, telling us their day-to-day work with ketamine-assisted therapy. So I'm gonna briefly introduce each one of them. We have Dr. Michèle Anne Barocchi. She is a PhD at the University of California, Berkeley, and she's the co-founder of Maps Italia. Ciao, Michèle. Then we have Dr. Dominique Morisano from Canada. She's a clinical psychologist and professor at University of Toronto. She has extensive expertise in psychedelic assisted therapies and a member of Simepsi. Ciao, Dominique. Welcome. Then we have Professor Gerhard Gründer from Germany. He's a professor of psychiatry and also a medical director of the Ovid Clinic in Berlin, Ketamine Clinic. He's also in charge of the first European program for the compassionate use of psilocybin, and it's really an honor to have you here with us. Thank you so much for your time.
Thank you.
And then last but not least, we have Professor Andrea Fagiolini. He's a professor of psychiatry at University of Siena, Italy, and he's an expert in mood disorders and psychopharmacology. And he's one of the major experts in Italy about esketamine and ketamine therapy. Ciao Andrea, benvenuto.
Ciao.
You're representing Italy, so all eyes are on you. So, you know, basically every week there's some kind of news about ketamine-assisted therapy. Studies, they come out and they're published all the time, comparing also ketamine to esketamine. And just recently in Norway, so in Europe, ketamine has been approved for use, taking precedence over esketamine in the public healthcare system because of its competitive cost, right? And in Italy, we have esketamine for treatment-resistant depression, but we can also use ketamine off-label in certain circumstances. And still, it's not a very common therapy compared to other countries. So that's why we have all of you here, so that you can tell us what you do in your country. Maybe we can learn something and improve our ketamine-assisted therapy. I'm going to start with Michèle, because she's in between two words. She has also personal experience with ketamine, and she's been working between the United States and Italy. So just based on your work and your experience, what differences have you seen in ketamine-assisted therapy between the United States and Italy?
Well, first of all, I'm going to try and hold my internet energetically because I'm living in the countryside in Tuscany and the wind is taking a toll on the connection. So I hope it is supportive for me to join the discussion. So thank you for the opportunity. First of all, thank you, Caterina. Thank you, Federico. And I just want to put my being here in context. I'm a trained scientist in molecular immunology, but after a nearly fatal accident 10 years ago where I lost my left leg, I switched careers and went into more mental health and healing practices. And so I actually came across ketamine in 2022 of February. I'd never really heard about it. And it's because I was living with chronic phantom limb pain, a pain that is so debilitating that it's very difficult to do any kind of work or live in society. So someone suggested that I try ketamine therapy because it could help with the pain. And I said, okay, let's do it. So I actually went to San Francisco, seeing that Italy was not open to using off-label therapy. And if I were to need or require ketamine therapy in Italy, I would have to have a diagnosis of a drug-resistant depression. So I was actually sent to the Polaris Institute in San Francisco, and that's where I received intramuscular ketamine injections. And actually, it was the only cure that helped actually sever the phantom limb pain. And since then, since 2022, after living for 7 years with this debilitating painful symptom, I was free of pain, and it was really, truly remarkable. And so I started working with Phil Wolfenson, who created the Ketamine Institute in Marin, and he actually just received a grant from the FDA to study ketamine therapy and people with phantom limb pain, mostly people who have had amputations. And so my thoughts between what's different between the United States and its use in ketamine and the Italian landscape is that there's not much access in Italy to ketamine therapy, only if you are diagnosed with something like severe depression. And I think it's really unfortunate because there's so many people suffering from chronic pain that could really use this therapy. And so I've kind of shifted my work to look into these more molecular and social and cultural landscapes and see how we can actually open dialogue and open some kind of window so that people can actually have access to these therapies. And so that's my contribution. I mean, I actually did the ketamine therapy training in Polaris, and I think also Dominique did that as well. And really, that place is a place where you learn to create safety for people because ketamine can be a very intense experience, especially when it's injected. And I think there's a lot of opportunity in Italy for the use of this kind of injectable ketamine therapy. I know right now only Spravato is being used, but it's not even being used in a container that is appropriate for therapy. So I think there's a lot of opportunity for learning about how we can set up a regulatory landscape and really kind of question how we can provide this care to people who really need it. Yeah.
Thank you, Michèle. Yeah, it's true. We don't usually use ketamine for chronic pain, but of course we can implement maybe in the future. So I would like to ask Gerhard, basically just tell us a little bit about your work at the Ovid Clinic in Berlin. It's a ketamine clinic, right? So I know that also in Germany you use esketamine, but why did you decide to focus on ketamine, and what type of patients do you usually treat? Is there some form of psychotherapy involved, and also what type of outcomes have you seen in your patients? Just tell us a little bit about basically your day-to-day work.
Yeah, so first of all, thank you for inviting me to this webinar. And I would like to also mention Daniele Damiani, who contacted me and invited me, Daniele Damiani from Simepsi. So thank you for including me. And so I have actually two positions. So I live in two different worlds. As you said, I'm a professor of psychiatry. I'm a psychiatrist also at the Central Institute of Mental Health in Mannheim, which is a large university hospital and a research institution, actually very large, one of Europe's largest research institutes. And so at that institution represents actually the usual university environment for using esketamine or ketamine. So before esketamine was approved in Germany or in the EU in 2019, ketamine was used in Mannheim as in a strictly pharmacological model, so off-label in treatment, mostly in treatment-resistant depression. Because in treatment-resistant depression, we have most of the data, so the strongest evidence. When I met Andrea Jungaberle and Henrik Jungaberle, with whom I run the Ovid Clinic in Berlin, we were thinking of something else. We wanted to create an infrastructure that goes beyond the classical psychopharmacological model. So in the clinic, in most hospitals, and not only in university hospitals, ketamine treatment is established in I would say most university hospitals, but also in many state hospitals, psychiatric state hospitals. So in those clinics, it's usually just used as an infusion in a usual hospital environment. So a wake-up room, a cold environment. You just infuse the patient the drug, and it's really considered a classical psychopharmacological treatment. So when we created Ovid in Berlin, which used to be a private practice, and now a while ago we also created a day hospital. It's a psychiatric day hospital in which we apply ketamine as part of ketamine-assisted psychotherapy. So we believe in the classical model, the dissociative effects or the psychedelic effects of ketamine or esketamine are considered side effects. We believe that we could use the altered consciousness state as part of the experience and part of the treatment. So we embed the pharmacological model as part into into a treatment plan, into psychotherapy. So we created an environment, rooms, which are more like living rooms, like in psychedelic treatment, living room environment. There's always a therapist with the patient during the infusion, and there's integration of what has the patient experience. And there's also, of course, music. We have music as usually music is part of the psychedelic assisted psychotherapy. We implemented this also into ketamine assisted psychotherapy. So this is really very different from the usual ketamine clinic. So you introduced Ovid as a ketamine clinic. We don't like this. We don't like to be called ketamine clinic because there are so many ketamine clinics, especially in the US, which have just the classical pharmacological model, the pharmacological intervention. They just put ketamine or esketamine into the patient, and that's it. We are a psychiatric hospital that uses ketamine as part of the whole treatment plan. Yeah, that was a long story. I hope I made it clear.
Yeah, that's great, actually. So, following on what Gerhard said, Dominic, he said important things, about the setting for the patient, and of course the integration, right? So, based on your expertise, how important is the integration part in the ketamine treatment? And, is it possible to have no type of psychotherapy or integration? And in that case, are there any risks for the patients or any limitations, both from a clinical and an ethical standpoint? What do you usually do with the patients you have with ketamine?
Yeah, a good question. And I'm just want to say I'm happy to be here and having this conversation with you all. I thought it would be useful just to kind of put my own experience in context as well, because there's, titles and then there's what we've actually done, right? I went back to school for psychedelic assisted psychotherapy in 2019. And when I got out, I was interested in incorporating ketamine into my work. But I realized that I needed to do a lot of additional training. And so I actually did 4 or 5 ketamine assisted psychotherapy trainings after I did a 1.5 year training in psychedelic assisted psychotherapy, because I felt like even that 1.5 years wasn't giving me what I needed to be able to provide the kind of support I needed to provide in ketamine assisted psychotherapy. But immediately I was given the opportunity after training to be in a leadership role at a major psychedelic company that was working across North America, across the US, across Canada, and in the Netherlands with different psychedelic assisted psychotherapies. And we ended up opening up about 12 ketamine assisted psychotherapy clinics. And I keep saying assisted psychotherapy because they were all assisted psychotherapy clinics. And one of the keys that I have been implementing in my own practice, because I left working with that company in late 2021 and have been doing a lot of consultation and teaching and practice with other places, as well as in my own private practice, is I basically have really come to terms with the fact that we need the amount of preparation in terms of time as that we spend in session with the medicine, and sort of an equivalent amount to the amount of time we spend in integration. So like a 1-to-1-to-1 ratio of preparation, treatment with the medicine itself, and integration for the experience. And I find that with my patients, at least, that's been kind of a minimum for having people be adequately ready for the experience and ready to kind of do the work to integrate what they've just experienced. However, there is a difference between ketamine IV treatments and, and low dose ketamine treatments, and this esketamine treatments, in my opinion, and ketamine assisted psychotherapy, which is Gerd was insinuating is using the ketamine experience, is using the altered state as part of the therapy. And I do, in my personal work with patients, I use the higher dose ketamine sessions to induce an altered state to help people come to terms with kind of thoughts, emotions, insights, basically things that have been sitting way under the surface for a long time, because I have seen that ketamine seems to be able to push stuff up to the top to be worked with. And in many of the ketamine clinics, like the typical ketamine clinics, people aren't, people are using lower doses of ketamine. And so not everybody is getting a psychedelic effect of the medicine. Not everybody is having visions or kind of having major insights during the session itself. It is more like a low dose treatment. Its pain treatments are very common in Canada with IV clinics, as well as treatment for mood. And the reason that we even got involved early on with the psychedelic work in terms of starting a big company and opening ketamine assisted psychotherapy clinics across North America was because we saw that ketamine therapy itself, like the IV treatments, do help with mood. They do help with trauma, like without psychotherapy. They do, right? Um, the problem is that in order to sustain the effects, people need to keep going. It needs to be ongoing. The effects don't last very long. And it's an uncomfortable experience, to be honest, for most people. And I can say that personally because I have done them at a pain clinic myself. Like Michèle, I have personal experience following an accident with being treated with ketamine at IV pain clinics. And it's a very different experience from doing ketamine assisted psychotherapy. And I think in some ways it has different aims. The issue is sometimes when people end up in those settings with big experiences or big emotions or big visions, and then they don't have the support to deal with what has come up. They don't understand what that meant. I've had patients myself in my regular practice who went for surgery or intervention following an accident and weren't even told that they got ketamine as the anesthetic for their surgery and ended up on a big trip on their hospital bed completely unprepared, right? And then had to, luckily, I was working with them so we could integrate it together in our regular therapy sessions. But a lot of people are not so fortunate, and I think that there is a disconnect in some ways between like the medical clinics that are providing ketamine in these settings without any kind of support and what is actually happening for patients. Because a lot can come up and move following these treatments, and without support to deal with those things, it can be very destabilizing, I think, for people. And I think the last thing that I'll say in terms of like this question is that I have used ketamine now with many personal private practice patients, and even those who I worked with for, let's say, several years, where we had gotten to some certain point in our therapy work together, and then maybe we got stuck on something, or maybe we knew that like there was something else that they needed to work on, but it wasn't coming up, it wasn't coming to the surface, or we were doing all the right things, we had tried all of these different interventions, but they were still depressed, or they were still feeling suicidal, or they were still struggling with addiction. When we integrated the ketamine assisted psychotherapy, and the way I do it is always in a series of 2 to 6 ketamine sessions, preceded by 6 to 8 preparation sessions, and followed by at least 6 to 8 integration sessions. When we added that in, people would make massive, massive jumps in therapeutic improvement. And like in some ways, I hate to say it because I'm not part of like the silver bullet camp in terms of psychedelic therapy, but sometimes the shifts felt miraculous. People that were suicidal chronically for over a year now, after stopping ketamine for many months ago, are no longer suicidal because we've been keeping up with the integration, even if we've kind of gradually decreased the frequency over time. And many people have been able to stop doing any integration therapy whatsoever and aren't even in treatment anymore. And one series of ketamine was enough to make massive treatments in their mood and well-being. So yeah, that's kind of where I'm coming from in my perspective, is if it's helpful.
Thank you, Dominique. So Andrea, we've heard a lot of great stuff from around the world, but we're here to focus on Italy, right? So what's the situation in Italy right now? As we mentioned earlier, we use esketamine, but ketamine can be used off-label in certain circumstances. So in your practice, when do you choose to use ketamine for which kind of patients? And we've listened to Gerhard and Dominique about a very structured way of using ketamine-assisted therapy. Do you have any support from psychologists or psychotherapists? And comparing Italy to these other countries, what are the major challenges that you're facing in your day-to-day practice?
Well, okay. First of all, thank you very much for having me. Now, here in Siena, we were the national coordinating center for all the esketamine registrational trials. And we have had quite a lot of patients treated with esketamine. Probably we are the center in Italy with the highest number of patients treated with esketamine. However, we had some budgetary problems because it's not extremely expensive, but yet it is quite expensive. And because of some observation showing that especially patients that are more agitated may be even better able to respond to ketamine intravenous than to esketamine. And because in the department I chair, we also have anesthesiologists, because I'm responsible for a department that includes neurosurgery, neurology, ear, nose and throat, and so on and so forth. We took advantage of these situation and we started administering intravenous ketamine to many patients. So as of now, we definitely have more patients receiving intravenous ketamine, and more recently we started administering intramuscular ketamine because it requires less monitoring and therefore less anesthesiologist time. We started just recently and we haven't seen much of a difference compared to intravenous ketamine. So we have a good experience with both esketamine and even more so with intravenous ketamine, which however we use it only for treatment-resistant depression, not only for treatment-resistant major depressive disorder, unipolar depression, which is the indication for which esketamine is approved, but also for patients with bipolar depression, which is an off-label use, but it works very well, and also for patients with acute suicidal ideation, because ketamine is very powerful in quickly reducing acute suicidal ideation, even in those patients that do not completely respond for treatment-resistant depression. We do not have experience for other indications, but following our initial meeting online, talking telephone call with Caterina, and also now that I listen to Michèle, I've learned many things from people that have experienced themselves some kind of an illness. I'm very intrigued and interested in testing, if possible, the use of ketamine as a potential treatment for at least some type of pain. And listening to Michèle right now, I was thinking that probably we can try it for several types of pain. I mean, that pain that is associated to central sensitization, to the wind-up phenomena like phantom limb pain. Actually, that's most interesting, because I've always known that I've seen some patients with phantom limbic pain, which kind of come from neuroplastic changes, from hyperexcitability, both in the spinal cord and in the somatosensory cortex after the loss of a limb. Since I knew that we had this meeting, I took a quick look at the literature in terms of what we know about the use of ketamine for treatment of pain, like the pain that is seen in phantom limb pain. I found quite an interesting, very small studies, very small randomized studies, some open label studies. For instance, I just read of a study involving 10 patients with refractory phantom limb pain, reporting 60% with substantial, long-lasting relief from pain. There are also other studies, excuse me, showing an immediate efficacy, but unfortunately showing that effectiveness was kind of transient, not lasting enough. But interestingly, they used relatively low doses, and they didn't use ketamine combined with psychotherapy. There is some biological explanation for the reasons why ketamine may work. First of all, because it's an NMDA antagonist, which kind of, by definition, reduces central sensitization and the wind-up phenomena that I was mentioning earlier. It means, progressive increase in the firing rate of the spinal cord neurons. And that plays a role in neuropathic pain and plays a role in phantom limb pain and so on and so forth, but may also play a role in other type of pain, such as I can think now to post-herpetic neuralgia, to diabetic neuropathy, or to the pain related to spinal cord injury, but also to other type of pain that is not associated with clear tissue damage, with clear nerve lesions like fibromyalgia, or chronic fatigue associated with pain syndrome, and so on and so forth. So it's possible that using higher doses than the doses that I've used in one of the trials, because there has been that one trial that is not too encouraging, showing that while patients are receiving the infusion, pain goes down, but then it doesn't last. But the doses in that randomized trial were very low. In the other case series with 10 patients, they reported lasting efficacy of pain. So it's interesting to study it, to study ketamine at higher doses, study, if possible, the combination with psychotherapy, which may be more difficult here because we have therapists here in the hospital, but it's not as easy as it may seem to find a therapist time. And also, I will need some help from those of you that have more experience, like Dominique or other of you, in order to identify those patients that may be better able to benefit from psychotherapy. Because thinking to my patients with resistant depression, for instance, there are some that during the infusion, they just want to be left alone. They're not open to any psychotherapy intervention. But there are also some that, on the contrary, are actually able to listen if you don't talk too loudly, if you don't challenge them too much, especially when we're doing intensive monitoring. If you talk to them in a very quiet way. They may have enough channels that are open even during the dissociation periods to receiving psychotherapy. So it will be interesting. I mean, I know that, for instance, PTSD patients can very well benefit from psychotherapy associated to ketamine administration, but I'm not as knowledgeable about who the patients are with resistant depression that can benefit from therapy, and even less am knowledgeable about who the patients are that we may try ketamine for pain that may benefit from associated psychotherapy.
I can see Gerhard raised his hand.
Yeah.
If you want to comment on this,
yeah, directly to this psychotherapy, we don't apply psychotherapy during the infusion. So that's usually actually really not possible. It's like with psychedelic-assisted psychotherapy, psilocybin psychotherapy, it's not possible to do psychotherapy. You leave the patient alone. You are just there to spend trust and presence. Psychotherapy actually begins afterwards. And then it seems to be crucial when you start. There is this work by Gül from the US, who showed that for certain drugs, you open a window for change. Let's say change. That's not what she showed in animals, but we believe you open a plastic window for change. And with ketamine, the window is relatively short. With longer acting psychedelics, it's longer, like psilocybin, it's 2 weeks probably, at least in animals. And with LSD, it's even longer. But with ketamine, you should probably, and there are actually now small studies which show that you should probably apply psychotherapeutic interventions very soon after the application of the drug.
Dominique, please.
Yeah, basically, I mean, I think, and I would be super happy to talk to you more, Andrea, because it's a passion area for me, obviously, and for you, I think. But basically, I have to say that, I usually work at this point with sublingual ketamine, although I've also worked with intramuscular quite a bit, and it is difficult with IV to just even physically kind of be by and be present with somebody. And it's not been, because oftentimes people are at this like level, for a period of time, it's not the same. But when I'm working with people, I actually do some intervention, but it's a little bit different than normal psychotherapy. So at the beginning of the treatment, as people are starting to experience the effects, especially in intramuscular, where it's more of this like arc like this, sometimes it can be anxiety inducing, sometimes it can be upsetting or scary to people. And so usually at the beginning of that, me and also like many therapists that I've trained, we and I think in the model that Michèle received it as well at Polaris, because they do this kind of work as well, is we provide some grounding at the beginning, sometimes some meditation at the beginning to help people, soothe people into the experience and remind them of their intentions for their work. We always set intentions in preparation. And then sometimes like people are fully out during the experience, but they feel your presence. And, if you've ever tried to leave somebody that has you by them in an intramuscular ketamine session that is fully on a big trip, let's say, they feel it when you leave. They feel it when someone knocks on the door, and they might not notice it. I had an experience once where I was with a patient, and somehow someone not like didn't realize somebody was in the room, and these two men kind of barged into the room when we were doing this treatment. And my patient under the ketamine didn't, the only response that you could see was hyperventilation. So he started to go, right? And so, he didn't shout out, he didn't open his eyes, he didn't take off his mask, but you could see that he was affected. And so immediately after, when he started to come out, we talked about it. We talked about like, how were you doing? How did it feel? How do you doing now? And then we talked about anything that he had experienced during that session, all the insights that he had gained, because he had gained many insights, and many of the patients do gain a lot of insights during their journeys, and they sometimes don't remember them the next day. So it's important for the therapist at that point to jot them down. And then when you're doing the integration, and I always do it the next day, the next morning, to kind of fit in that 48-hour window that Gerhard referred to, that's when the real kind of therapeutic development can begin. And the reason that we started including this from the get-go, and the reason we kind of pushed this as part of our treatment in that company I was a part of across North America, is because we wanted to see if the benefits that people were experiencing in intravenous ketamine could last longer without continued treatment if we added in this kind of psychotherapeutic support. And that is what we found, that people's effects were, they could stop treatment. I've had people that have never had to return for ketamine again after 6 sessions, like many people, most of my clients actually. And then some that have more chronic or more severe issues, it's been like a year later, we'll do another series of 6. And then a year later, we might do another booster of 2 sessions or something. And that's enough to kind of re-pick up that neuroplasticity, that kind of period of shifting, and make a difference. So, but I will say, with the people that you were talking about that don't want someone to sit by them or support them, in my work, like, that's not presented as an option. And there always are going to be those people that don't want to do work. They just want the medicine, they just want the treatment, and that's it. And they're happy to keep coming as long as, you know, they can pay for it or someone else will pay for it. But the way that we always presented it at the company I worked for, at the different places I've worked, is that it is an inextricable, like, you can't take it away. You can't take the preparation and the integration away from the ketamine. Without the integration and preparation, you don't get treatment. It's like part of that process. And when I've been working with therapists in Ukraine recently who are working, they're using ketamine with recent war veterans. They've recently been trained in ketamine-assisted psychotherapy. And that is something we are also emphasizing, that if people don't come back to do the integration with the group, then they aren't coming back for another ketamine session. So yeah. And sorry, one more thing. Sorry to talk so long, but sometimes unexpectedly in the middle of a ketamine session, someone will have an outburst or an insight. And that is when you may intervene just a little bit. Like, I had someone once who was coming to me for treatment-resistant depression, but had a very intense ketamine experience, actually was vomiting quite a bit. And I was trying to just be there to support his kind of temperature, opening the windows, kind of just like giving him a bucket kind of thing. But then in the middle of that experience, he shouted out, "I hate alcohol." He had not even mentioned alcohol as being an issue, right? And I said, "You hate alcohol?" And he said, "I hate alcohol." And I said, "Well, why do you hate alcohol?" And he said, "It's a poison. I don't know why I have it. I don't know why I take it." And I said, "Okay, thank you." And I just wrote that down. And then we didn't talk about it again. I continued to support him through the session. And then the next day when we met, we talked about it. And he went down, I think he had like a 90% decrease in his drinking, from which was very heavy, from that one session, his very first ketamine session. And I finished seeing him about 8 months later, and he hadn't returned to his previous level of drinking. So that's the kind of stuff where it's important to have someone there, but sometimes you don't know until it happens. And we found that sometimes it feels like, at the place I was working at, like when we didn't have a therapist in the room, it would still work okay. It's just that people wouldn't have as big experiences. There wasn't that safety and support that allowed people to really go deep or kind of get into the thick of what was happening with them. So yeah, that's all I'll say.
Thank you. We have Michèle that raised her hand, and then I have 2 final questions, one for Dominique and one for Gerhard, and then maybe Andrea, we can talk about all these wonderful things we've just listened. Michèle, is your connection working? In the meantime, just two quick questions. So Dominique, as Andrea mentioned, in Italy, it's quite difficult to have this kind of collaboration of psychologists or psychotherapists within the public healthcare system, right? And of course, one of the major issues, and we were actually talking about it just yesterday, you and me, one of the major issues is that we don't have therapists that are properly trained for psychedelic assisted therapy in general, but more specifically for ketamine assisted therapy. And so staff education is obviously a main challenge. So what do you think are the first steps we can take to implement this part in ketamine therapy? Because as you said, as Gerhard said, and also Michèle, integration is a huge part, right? So what are the first steps we can take?
Yeah. Well, the first steps are basically starting with, I used to work as an implementation scientist in public health in Canada. And we said that always the first place to start is with the early adopters, the people that are interested in trying things out, the people that are willing to take a little risk, go out on the ledge a little bit and explore and try new things. Not everybody's going to be in that position. And so, trying things out in a pilot way, and starting to do some, I think, smaller, like localized kind of training and education, even some health promotion about this as an issue might start to get the attention of different therapists, get the attention of different doctors, because, obviously, doctors can also be trained, and nurses can also be trained. I mean, we also, of course, want therapists to be involved, but like when I ran a ketamine assisted psychotherapy training this summer, we included some psychiatrists, we included a nurse, so different people can be interested in. The more that people know, the more that they're able to help. So I think that starting with some basic psychoeducation like this webinar, starting to think about, okay, well, what's different between regular psychotherapy and psychology, and what's different between regular ketamine, treatment, and what's the added benefit of ketamine assisted psychotherapy? Or this like augmented psychotherapy, right? Why would we do one versus the other? When could this be helpful? When is this more helpful? Who would this benefit? Who would it not benefit, right? And are there particular considerations when doing this kind of treatment that we need to take into account? And like, yes, there are a lot. So but one thing I found is that even though I did my full, I've done several years of psychedelic assisted psychotherapy training, and I do continuing education in it. I think that for ketamine assisted psychotherapy, to be perfectly frank, and some people might not agree with me, it's if you have certain skills as a therapist or as a clinician, like from the beginning, certain ways of working with people, your own emotional stability, you've done your own work, you have some kind of practice that keeps you grounded, and you are willing to do some reading, some education about this practice. And then we get into training. I actually think the trainings can be much shorter for ketamine assisted psychotherapy. Often they are experiential. We find that without having the experience itself of being under ketamine, it is really difficult for therapists to understand what that means. We would have experience where we opened up a clinic, and we would hire a new therapist who had no experience with ketamine. And they were a wonderful therapist. They helped so many people with all kinds of problems. But you put them in front of a patient who was on ketamine, and all of a sudden they were trying to do CBT during the middle of someone's peak experience with that medicine. So, someone's very gone and they're like, what about this? Right. And so, I had calls from the lead therapist at this clinic. Dominique, you need to get this person some experiential training so they know what they're doing, so they know what it's like to be on ketamine, so they don't try to talk over someone's peak experience. Yeah. So, that's the kind of training that I have provided. Like, we provide for people, and we arranged for all of our therapists. Like, we had like 75 therapists across Canada and the US. And that was extremely effective. We found that after like a 4 or 5 day training, people were pretty okay to start, and then it was about ongoing consultation, and mentorship or supervision in that case, and that's why I do all the consultation groups that I do, because I find that even in practice, therapists struggle with knowing when is enough, like how can they help a person, how can they help a client to determine what goals that they have in treatment, how can they help a client to implement changes after treatment, because we really emphasize in all the trainings that I do that the medicine is not the treatment, it is only a catalyst for change. So the ketamine is not the treatment, it is only a catalyst for the client to start making changes. And I have found that when I have clients that won't exercise, they won't sleep, they won't eat healthy, they won't meditate, they won't take care of themselves, they won't see friends, believe it or not, a ketamine session happens, all of a sudden, it's like some of those barriers break and we can start going on walks, or we can start doing some meditation, or we can make plans with that friend we've been avoiding calling. And these are the things that will keep those depression symptoms down, those anxiety symptoms down, and help the effects of that medicine to last much, much longer. So.
Thank you. And I will ask Gerhard the same questions. What do you think are the first steps we can do to implement ketamine-assisted therapy in Italy, especially Andrea earlier, he mentioned few conditions, right? Few indications for ketamine-assisted therapy. What type of patients do you mainly treat in your clinic? I'm sure the majority is about depression, but as we mentioned earlier, maybe chronic pain or some other indications, and what can we do to start implementing this in our country?
Yeah, so education of therapists is one thing, but I think the very first step is education of our colleagues about the therapy itself, so the potential, and that it's not really that it's not really very complicated to implement it in your daily practice. It's not complicated. You just have to want it, and then you have to do it. So I think we have to start with more education of colleagues about indications, how to do it. And the second step is specific training. And with regard to specific training, I agree with everything that Dominique said. I just would like to add that it's not really to be a therapist who's doing ketamine or psychedelic assisted psychotherapy is not a completely different thing from a usual so-called usual psychotherapist. So 90% of what you do in ketamine, or at least in my view, what you do in ketamine or psychedelic assisted psychotherapy is usual psychotherapy. You just have to add certain skills and certain experiences. So it's really not to work with these drugs is not a completely different thing from what we are usually doing. I think a good education in psychiatry and psychotherapy, psychology is really the basis. And then you have to add a few things. There are training courses everywhere now, available both in Europe and in the US. And then it's really possible for almost everybody. Yeah, that's at least my view.
Thank you. So Andrea, we listened to a lot of stuff. I don't know if Michèle can speak or not, but
Apparently she's here,
yeah,
but she's not here. Yeah,
no.
she can hear us.
Yeah, so we're almost out of time. And you manage one of the main national reference center in Italy for esketamine and ketamine. And we've heard a lot of great suggestions from our colleagues. So what do you think we can do in Italy to implement ketamine-assisted therapy? And what do you think are the main challenges we have now to, both Dominique and Gerhard talk about the experience also for the therapists. Maybe that's a little bit challenging for us. But what do you think we can do? We can do more studies, maybe. In your center, you have a lot of patients for, I don't know, a trial or something. What can we do? Tell us.
Well, first of all, I have to honestly say that I learned a lot, and actually, I'm now even more convinced to try doing something more than what we are already doing. So, practically, what I may be able to start doing beginning tomorrow is either to talk to my colleague that supervises all psychotherapies, because I mean, it may seem stupid or simplistic, but I actually had never studied this possibility, and I was kind of reluctant for the very reason you mentioned, because in my mind I was thinking about ketamine-assisted therapy as a therapy done while the patient was dissociated. And since I've really seen hundreds of patients in dissociation, I just didn't believe that the patient was able to receive a therapy. Whereas what both Gerhard and Dominique said is totally logical. It makes sense. I mean, I do understand now, as ignorant as I am in terms of psychotherapy, that if before giving ketamine, you establish a relationship, you start doing some therapist, then you're just present. I mean, this helps you linking with the patient. And then when the session is over, you do that again. That makes sense. So tomorrow we'll talk to my colleague here that supervises psychotherapy, and we can try with some patients and see how it works. So that is probably the easiest step. In terms of starting using ketamine and therapy-assisted ketamine for other conditions, what I may do is looking more in depth at the literature. If Michèle is willing and able, if she hasn't done it yet, to just write her case as a case report to be attached to a revision of the literature. We can write a paper where we report what has been already seen, but we also report the voice of a colleague that has tried these on her own. I mean, she's tried on her own body. And so that can be a way for us to have some scientific basis that will help us to get the approval from the management of the hospital. I mean, I will not be able to administer ketamine to a patient like with phantom limb pain, unless I publish a paper first in which I report what the literature says, I report what the neurobiological background can be, and maybe it can be important even to write down the experience even of one single patient like Michèle. Once this ground has been built, then we can start either doing a study or just administering the treatment, because I think the hospital will approve it. In that case, once we have 10 or 20 patients that have tried, then we can design a randomized trial.
That's great news. Great news. You all have email contacts, so I'm sure that if you need any help, everyone will be willing to help you. So Michèle, if the connection's working, you want to say some words before we close?
Can you
Because
hear
the time
me?
is almost up. Yes, we can hear you.
Oh my gosh, how amazing. Yes, very interesting conversation. I'm so happy to have had this and met Andrea Fagiolini finally and Gerhard. I think it's a great opportunity to bring in training to facilitators, because I think it is very important to have a safe environment on which to do this work, and also to have people, like Dominique said, who are trained in the experience, because these are very intense experiences. I only did 2, but I would not want to do those alone. And I think also what Gerhard brought up, which was Gold Dolan's work. I met her this summer in San Francisco, and yeah, there's a 3-day time window, and so this integration after these very intense medicine sessions should be a requirement for the patients that are being treated in Italy, because those windows are the reopening of critical periods, and they're periods where people can learn new behaviors, and there's neuroplasticity. So when you're looking at laser pointing into a depressive symptom, those are really key periods of times that are needed to have a supportive environment, such as a therapist who really knows what they're doing. So I'm very happy to help Dr. Fagiolini with writing up something. I've written something up for Phil in the United States, and I'm happy to do this work to help and support open and connect people who need this therapy in Italy. And also this link, very important link between, pain and depression, and depression and pain. And I think if a lot of these people who are living with chronic pain, most of them have depression. And I would hypothesize that by targeting the pain, you can also get rid of these depressive symptoms, because it's not a happy situation to be living with chronic pain. And if there is a medicine and a therapy out there that is available, I don't see why it shouldn't be available in Italy.
Thank you so much. So our time is up. I'm sure we can talk for hours about this thing, but for now, thank you very much for your time. It's been a pleasure. I would like to thank Illuminismo Psichedelico and Associazione Luca Coscioni for organizing this event, and of course, Simepsi and Maps Italia for their collaboration. And we all continue and we commit to advancing psychedelic research and education in Italy. So thank you to all these organizations that today they were together for a very special occasion. Thank you so much. Grazie mille.
Thank you,
Ciao a tutti.
Caterina. Thank you.
Grazie.